Welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP Cable Television Channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could join us today. My very first guest today, the incredible Dr. Jim Disario, gastroenterologist. Dr. Disario, thanks so much for being here.
Well, thank you for having me.
Dr. Disario, I took a few minutes last night to go over your extensive resume. I read how you have received NIH grants, you're a professor, you teach gastroenterology, and you have taught and worked at quite a few places. You know, for the size of this county, we're really lucky to have a doctor with your type of experience and education here. Tell us a little bit about these NIH grants. Teach our audience, whether they're listening or viewing, what is an NIH grant?
Well, that's a very good question. The National Institutes of Health is the branch of the federal government that provides funding for medical research. And there are various institutes within the National Institutes of Health, and the one that I worked with mostly was the National Cancer Institute. And these are major research studies where you submit a proposal and it's reviewed by a panel of world-renowned experts, and if you make muster, you get the funding and you get to perform the studies. And we're talking about studies that may last 5-10 years. Some of the ones that we looked at were on the genetics of colon cancer and ways to stratify people for the risk of developing colon cancer, and ways to prevent colon cancer, including using drugs, dietary manipulations or maneuvers, and other such factors.
Well, Dr. Disario, that's a great segue to the main topic that I want to talk about today, of course, which is colon cancer. But before we get there, tell us a little bit about the life of a gastroenterologist. I'd like to know something about how you got to be a gastroenterologist, what's the training like, and about your average week. What do you do during the week? Let's start with your training. How do you get to be a gastroenterologist?
Well, first you go to university as an undergraduate for 4 years, and then you go to medical school for 4 years. Then you do a residency in internal medicine, which is 3 years after medical school. You can also be a gastroenterologist in pediatrics, in which case you would do a 3-year pediatric residency.
So let me interrupt you one moment. So Dr. Disario, I think an important point for our audience is that you could have elected to go out and practice internal medicine. You completed your internal medicine training, so 4 years of college and 4 years of medical school and an internal medicine residency, and then you went on to do special training in gastroenterology. Isn't that right?
That's correct. I actually did practice internal medicine for 4 years in a government program where I was stationed overseas and then in Washington, D.C. And then I went to do my gastroenterology training, which is currently an additional 3 years of training only in digestive diseases and in endoscopy for digestive diseases. And if you want to specialize beyond that, there's even more training.
Well, that's very impressive, Dr. Disario. So tell us a little bit about your average week. Are you doing endoscopy? Are you doing colonoscopy, which we're going to talk about in a moment? Are you seeing patients in the office? What's your average week like?
Well, in general, I do endoscopy, be it colonoscopy or endoscopy to look at the stomach, or specialized procedures to look at the bile duct or the pancreas or the small intestine, often in the mornings. And then I will see patients primarily in the afternoon. Sometimes we do see patients in the morning as well. And then, of course, I work in the hospital as well, doing specialized procedures and covering the hospital for routine needs.
Well, Dr. Disario, just on kind of a personal note, one of the reasons I invited you to come on the program, not only because you have an excellent reputation, is because I will oftentimes see your name on the emergency room board and on the operating room schedule, you know, I feel that I go into the emergency room a fair amount and take care of injured people as a plastic surgeon, and I'm surprised so often how I see you doing emergency ERCP or doing emergency procedures. You're a hard worker. It's really very impressive. We're lucky to have you around. So, Dr. Disario, the main issue that I would like to talk about during the program is colon cancer. And I know that you are a recognized expert, actually. You're a professor of medicine and gastroenterology. First of all, can we talk about the difference between a benign colon polyp and a colon cancer? Now, how do you teach your patients in the office the difference between a benign polyp and a polyp that has become cancerous?
Well, that's an excellent question. Polyps are growths that occur on the lining of the intestine. They are caused by genetic mutations, and those genetic mutations can either occur sporadically or spontaneously, which in most of the cases, or they can be inherited as well. There are environmental factors that play into this, including diet, lifestyle, body size. Obesity is a factor in growing polyps, smoking, these sorts of things. And polyps are benign to a certain point, and there will be a point that some polyps will turn into cancer. The difference between a polyp and a cancer is that the cancer invades into the surrounding tissue or spreads via the bloodstream or the lymphatic channels to distant organs. So the difference between a benign polyp is that a polyp stays right there on the lining of the colon, and if that polyp turns into a cancer, it grows through the wall of the colon into adjacent organs or spreads elsewhere in the body. That separates polyp from cancer.
Okay, so Dr. Disario, a person can be diagnosed with a polyp of the colon, and certainly that doesn't mean that they have colon cancer. Is that right?
That is absolutely correct.
So I think that's important to emphasize to our audience, because aren't colon polyps fairly common, or are they rare as well?
No, they're very common. In fact, almost half of people over age 50 have polyps.
Okay, so even though they're benign, can a colonic polyp be troublesome at all? Like, can they bleed, or do they cause pain, or can they obstruct?
Occasionally, a polyp will become so large that it could cause a problem in and of itself, but the main problem with polyps is that they can turn into cancer.
Okay, so I love these segments where I learn a lot. Dr. Disario, can you get a colon cancer that does not arise in a polyp? Can it just, say, grow from the lining of the colon itself, or do they all come from polyps?
The vast majority of them come from polyps. There are certain conditions where a cancer may develop right away from the lining of the colon, and that usually happens in people with unusual inherited syndromes or genetic mutations that predispose to this, or in people that have inflammatory bowel disease, such as ulcerative colitis or perhaps Crohn's disease, who may just develop a cancer without the polyp.
Okay. Well, I'm sure we could go on talking about this for hours, and I know that you're a recognized expert in this. I appreciate you being on the program, Dr. Disario. So an important thing to our listeners and viewers is how and if we can prevent a polyp from becoming malignant, or how does someone prevent colon cancer, or can it be prevented?
Colon cancer can be prevented, and the way that we prevent it is to remove the polyp before it turns into a cancer.
Okay, so how is a polyp removed?
It's removed with a procedure called colonoscopy. And what that entails is that the person will drink some medicine that washes out the colon, and then with the person asleep, a long flexible tube with a light on the end of it and a channel that we can put instruments through, we can direct that through the entire colon and look at it, and if we see polyps, we take them out right through the endoscope.
Oh, okay, so it sounds like colonoscopy is not only a diagnostic procedure, but it can be a therapeutic procedure. Is that right?
Absolutely.
So my next important question, and as I said, I'm learning a lot during this segment. So who gets colonoscopy? Who do we recommend to our listening and viewing audience? Who should call and get a colonoscopy and get screened?
Everybody over age 50. It is recommended that everyone over age 50 have colonoscopy performed regardless of whether there are symptoms, regardless of whether there are any other factors that may put someone at risk for having colon cancer, particularly a family history.
Okay, so I think in terms of public health education, this is worth the price of admission alone. So in our audience, if there's anyone over 50 who has not had a colonoscopy, they need to call and get one scheduled. It sounds like it's a potentially life-saving procedure.
That is correct.
Okay, so you know, Dr. Disario, this is a little bit of a delicate topic. Colonoscopy has a reputation that it sometimes can be difficult. To some people, it's embarrassing. Do they get anesthesia? Is it uncomfortable? Is it painful? Tell us something about the procedure.
Yes, for the procedure itself, the people take the preparation, as I had mentioned, that flushes out the colon. And then when you come in to have the procedure done, you get an IV, and the people are given sedatives and painkillers blended together that makes the people sleep. Now, it's generally not full anesthesia as you would do for surgery, but it is such that people are asleep and have no recollection of the procedure in the vast majority of cases. The procedure itself, if done without anesthesia, is moderately uncomfortable. And so we can do it with the type of anesthetic that I'm talking about.
And roughly how long does it take?
It takes about half an hour to do the procedure.
Okay, so once again, I think we need to emphasize this, and if it's okay with you, before the end of the segment, we're going to give out the phone number, and I think you're associated with a group.
That's correct.
So screening colonoscopy is a potentially life-saving procedure. You have ways to make it tolerable, if not comfortable, and you can diagnose polyps and remove potentially malignant polyps with colonoscopy. Isn't that right?
That is exactly right. And, you know, in fact, if you look at everything that is done in medicine, if you look at the outcome of whatever treatment or intervention it is for the resources invested in it, there is almost nothing that approaches colonoscopy because it is very effective at preventing cancer. It prevents cancer. It is much more effective than pap smears or mammograms or treating high blood pressure or treating high cholesterol. That doesn't mean those other things shouldn't be done, but on the scale of things that's done in medicine, colonoscopy is one of the most effective things that can be done.
Well, excellent. And before the end of the segment, I'd like to give out your telephone number, or maybe there's a website when people can just pick up the phone in the morning or this afternoon if it's not too late and schedule their screening colonoscopy. Dr. Disario, what about prevention in terms of, for example, let's say someone comes into the office and they tell you that their sister and their mother and their grandfather and two of their aunts have all had colon cancer. Is there a way that they can, say, present or prevent the tendency for them to develop cancer? Can they take vitamins or anti-inflammatory agents, or do they need to get screened earlier? Like, what do we do for that person who seems to have a definitive family tendency towards colon cancer?
Well, colonoscopy is the best thing that can be done at present. There's been a lot of research done, and I've done some of that research myself, looking at drugs that can prevent polyps and hopefully prevent cancers. And indeed, it appears that there are some drugs, and those are the drugs related to aspirin, but the side effects of them limit the use of doing this. And colonoscopy is so effective that this is the way that it should be done. And if you have a family history, it depends upon the relative, the degree of how close that relative is to you, and the age of the relative. So a first-degree relative, a parent, a sibling, or a child, which would be unusual, but who has colon cancer doubles your risk of having colon cancer.
I see. Well, Dr. Disario, does colon cancer have a predilection in any certain ethnic group, or in Europeans or Africans or Asians, or does it depend upon diet? Or you did mention ulcerative colitis and Crohn's disease. So that's a certain subset where that chronic inflammation perhaps increases the tendency towards colon cancer. Is that true?
That is exactly true. And there are some groups of people who do have increased rates of colon cancer, and it's interesting because there are as I say, there are environmental factors, particularly diet and lifestyle, that play into it. For example, Black Americans have higher rates of colon cancer than do white Americans, but Black Africans don't get colon cancer.
Well,
it's unknown in Africa.
That's fascinating. So a Black person growing up in Africa will rarely get colon cancer.
Almost never. Until recent times, when in some countries, such as South Africa, it's become more affluent and the diet and lifestyle has changed for some people to reflect more of the diet and lifestyle that is in most developed Western countries. And in that group of people, the colon cancer rates are going up.
That's amazing. So do we know what it is about the diet, and did you say lifestyle changes? Is it a certain type of food or a certain type of cooking?
There's been a lot of research done in this, and we actually participated in a lot of this before I came here. And it appears that it's the caloric density of food is one way of putting it. Otherwise, high fiber foods, foods that are not processed, and low meats, low red meats, low barbecued things, low fats. Those are the types of things in a diet that probably help to minimize colon cancer. But none of the interventions comes close to colonoscopy in terms of preventing colon cancer. And I think it's important for people to realize that you can't just change your diet and start eating whole wheat bread and think that's going to prevent colon cancer, because it's not. But it may help. And you know, colon cancer is the second most common cause of cancer death in the United States in men and women. And so this is a very significant problem, and there is an excellent solution in colonoscopy for prevention.
Well, Dr. Disario, I certainly appreciate this very valuable information. Now, just briefly, can we talk about other ways to perhaps diagnose? Can the radiologist sometimes do, I've heard about virtual colonoscopy, I've heard about certain high-resolution barium enemas. Are those useful adjuncts, or is colonoscopy still the gold standard? What do you consider those other tests to be like?
Well, that's an excellent question, because there are other ways of screening for colon cancer. And screening is when people come in with no symptoms and you say, I'm at risk, everybody's at risk for colon cancer, we'll do the colonoscopy to prevent it. People that have symptoms, if they have rectal bleeding, or if their iron is low, or they have abdominal pain, or change in their bowel habits, something of that nature, that would be different. That would raise our index of suspicion and the chances that they might have something, and then we're doing studies that are diagnostic rather than screening. But when there are other tests for screening, going back many years, simple tests to look at blood in the stool have been done, thinking that, well, if cancer's there, it'll probably lose some blood, and if you test the stool for blood, even though you don't see blood in it, and it's positive, that may pick up the colon cancer. And that only picks up about half of colon cancers, so that's not good enough. There's a shorter scope called a sigmoidoscope, and that looks at the lower third of the colon, not the entire colon. And that is done without sedation, and many people have had unpleasant experiences with that, and has discouraged some people from coming back for screening. Also, you might think of it as something like doing a mammogram on one breast, because why would you want to look at only the lower third of the colon, missing 2/3 of it? Then there's the virtual colonoscopies, which are CT scans. And there's been a lot of press about that here lately. And the CT scans are getting better and better. And the way those work is you take the same preparation you would take for a colonoscopy. So you have to drink the preparation that cleans out your intestine, and you go into the X-ray suite, and you have to inflate air into the rectum and fill the colon with air so that it can be seen on the scan, and then a scan is taken. And there's been a lot of progress in those. And there's been, as I say, a lot of press lately. The problem is, although the CT scans pick up 9 out of 10 large polyps, the kind that are at highest risk for turning into cancers, they only pick up about half of the small to medium-sized ones, and the large ones come from the small to medium-sized ones. So you're missing a lot. The other thing is, if you see it on a scan, you've got to have the colonoscopy.
I see.
And scans have radiation, and when you're doing tests to screen people to prevent cancer, and you have to have them done repeatedly, and you know, if a screening test is normal, it's every 10 years. If there's polyps, it's more frequent than that. The radiation exposure is something to keep in mind. So there's a lot of issues with the CT scans or the virtual colonoscopy that have yet to been resolved. And in fact, the United States Preventative Task Force, which is the overall group of experts that looks at the outcomes of procedures, and we will be hearing much more about this type of thing in the future.
Of course.
Has deemed that the virtual colonoscopies are not ready for use as routine screening at present. Maybe in years to come. So the role of it would be if somebody can't have a colonoscopy for some reason, that would be an option. Or if somebody won't have a colonoscopy for some reason, that might be an option. But as I say, the insurance companies generally don't pay for it in those, for people that just want to have it or who want it for regular screening, because it's not as effective as colonoscopy and has some side effects that are worth considering.
Well, that's an important point that you raised. Now, is screening colonoscopy generally covered by insurance companies, or do people have to pay for that themselves?
Oh, it's covered by almost all insurance companies to one extent or another. And as with everything that's done in medicine, there generally are co-pays. But it is covered by Medicare. It is covered by all of the major insurance companies.
Well, Dr. Disario, I think we only have a few more minutes. I want to make sure that we give out the phone number. Mm-hmm. So I think it's worth repeating in terms of public health. Anybody over 50 should have a screening colonoscopy. And is there a website or phone number that we can give out?
Well, yes, of course. Our office is Monterey Bay Gastroenterology Consultants, and the telephone number is 375-3577. That's area code 831-375-3577. And our website is
so you do have a website. So I'm
yes.
going to repeat that phone number again. So 831-375-3577, Dr.
Yes.
Jim Disario. And you do have a website.
And there also are, we have 8 other gastroenterologists that work in our practice, all of whom are expert in colonoscopy.
So you're in a group now with 8 others. Well, Dr. Disario, we're so fortunate to have a gastroenterologist, as I said, with your type of training. You've published many papers. You're an NIH grant recipient. And you also have a professorship. You do have an appointment, I think, to a university, don't you?
Yes, I do, at the University of Utah, where I spent a few years.
Well, that's excellent. I wonder, since we do have a few more minutes, can we talk briefly about the other end of the GI tract? Now, I know that you do a lot of upper GI endoscopy. Isn't that right? There are lots of other things you can do by inserting the scope through the mouth and down the esophagus, right, into the stomach and the duodenum.
Yes, there are. And of course, we can look at problems that occur in the upper GI tract, heartburn or esophagitis. There's a condition called Barrett's esophagus, which is a precancerous condition that's being increasingly recognized as problematic. We can look for ulcers and things of that nature. And we also have more advanced procedures where we can go through the mouth and the stomach and the intestine and actually get up into the pancreas and up into the bile ducts and treat problems that go on there. There's newer technology that we've got available where we can put tiny little scopes through our bigger scopes right up into the ducts and see the inside of them and treat stones or tumors that may be present and things of that nature. So there's a lot that we can do with endoscopes, and now there are even endoscopes that allow us to get through the 10 to 20 feet of small intestine using various technologies.
Well, that's amazing. Dr. Disario, most of the audience knows that I'm a plastic surgeon, and before I could do plastic surgery training, I did general surgery. So I recall many times we'd have a very difficult gallbladder case and a very difficult colon case, and we'd want the help and ask for the help of the gastroenterologist and work together on someone. For example, we'd sometimes ask for an ERCP, endoscopic retrograde cholangiopancreatography. Is that right?
Excellent.
It's amazing that I remember.
ERCP, yes.
Amazing that I remember that. So I know that you're a very valuable member of the community, and I certainly appreciate you coming on the program. Dr. Jim Disario, gastroenterologist. I'm going to give out that number again.
Please do.
375-3577. And in terms of public health, everybody over 50 is supposed to get a screening colonoscopy. Isn't that right?
That's the take-home message.
Well, it's worth the price of admission alone. Dr. Jim Disario, thanks so much for being here.
Thank you for having me.
I am Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to come right back after a very brief pause for a very good cause.